I want to introduce the next speaker, Michael Dawes. And in the interest of giving him his full time, I'm not going to read his whole biography that he's supplied us, which is extremely impressive. And he is running our addiction fellowship at our medical center, and he's on the full-time staff in Brockton. Please read his bio in the available information that you all have been provided with. But without further ado, I want to let Michael begin.
Morning, everybody. It's a pleasure to be here. I wanted to kind of just hit some highlights. This title has evolved over time as I was putting the talk together, because I was realizing how many intersections benzodiazepine have, not only in terms of those that are at risk for benzodiazepine use disorder, but also co-occurring sedative hypnotic related disorders and other mental health disorders as well. So the title is to reflect what we're going to actually talk about. Next slide. I don't really have any disclosures. A couple of points though. There really are no FDA-related medications to treat sedative hypnotic disorders, so a lot of these discussions are off-label. I will also add that as I was putting this talk together, I wanted to give you a little bit of my background. Before I was involved in VA and teaching with fellows and residents, which I've been doing for the past 13 plus years, I was very much involved with clinical trials in terms of human lab and clinical trials in a former institution. So I really do have a good sense of how difficult it is to do clinical trials. And as I was culling the literature for this talk, it really struck me how poorly some of the studies were done. But it's not so much for lack of trying, it's that this population that are using high doses of benzodiazepine with co-occurring disorders are extremely difficult to recruit and keep in treatment for clinical trials as well as clinical practice. So that's something just to kind of keep in mind as we're moving forward. And thirdly, I just wanted to share with you, just getting your input. I put some stuff together from my experience, both in terms of supervising fellows and residents, my own clinical practice in VA and outside of VA. I was struck, I moved here from San Antonio about 4 years ago, and just how much difference there is in regional practice in large VA settings, as well as in outside of VA, of how much difference there is in terms of benzodiazepine use. I've been struck by that here, that in the Northeast region, at least practicing at VA Boston and at Boston medical population, that there really is a fairly significant population of folks using high doses of benzos for many, many years and are particularly vexing to treat. So with all that said, let's move forward to the educational objectives. I've just hit the high points here. I just want folks to really have a sense of the therapeutic and potential harmful effects, not only benzodiazepine use, but that with co-occurring sedative hypnotic use. And generally, even though the focus is on benzos, it's actually rare that folks are using only benzodiazepines. They're using usually multiple sedative hypnotics, as well as other medications, and they each have unique and sometimes very dangerous interactions and complications that we'll touch on. Secondly, I wanted to touch on what are the actual risk behaviors to observe in terms of leading to misuse of benzodiazepines and other co-occurring sedative hypnotic use disorders. And lastly, I really want to spend the bulk of our time talking about case material and pearls in terms of looking at the psychopharmacological, but the psychosocial management strategies. For more than most other clinical trials, it really makes a huge difference in terms of clinical outcome if you can actually marshal and have effective psychosocial treatments with this population, probably more than most. And I also want to emphasize that this talk should be looked at in terms of the other talks for today, not only Dr. Chen's, but the whole of the discussions today, the algorithms and that. This population would be very, very difficult to put into an algorithm because the data, even the meta-analysis that I'll come to, are fair to poor. I'll just start off saying that, just because they're so difficult to engage in treatment, both for clinical trials as well as clinical case material. And we'll come back to that. Next slide. So just briefly to go over the typical medical indications for benzodiazepines include treatment for anxiolysis or anxiolytic treatment, sedative hypnotic for sleep, anticonvulsants, they've been used withdrawal management. I would mention also that benzodiazepines have been used to treat PTSD symptoms, but the data overall, if you look at it, makes not only PTSD symptoms worse, but it increased the risk of developing PTSD for folks who don't have it yet. There's fairly good data on that. It can also worsen aggression, depression of all stripes, unipolar depression in particular, and other substance use disorders. And if you want to read more in depth on that, this reference is at the end as well for Gina et al. It's actually a well-done paper, and I'd recommend folks looking at that. Next slide. In terms of the adverse effects, we'll kind of go in depth on each of these as we go through this in terms of addiction or misuse liability, sedation effects, psychomotor impairment, which could actually lead to falls, cognitive impairment. There's been some data on retrograde as well as anterograde or moving forward type of amnesia and cognitive effects. The physiological dependence and withdrawal, which we'll talk about, very similar to alcohol with a different time frame based on the pharmacokinetics, as well as increased death rates. And this is, I'm putting in bold just things that really we need to focus on as clinicians, that both alone and in combination with other sedatives and other medications, the death rates overall across all studies, Welsh probably describes it the best, but there's a number of articles in the past 15 years or so that show the increased mortality of all stripes happen. And the longer you're on it and the higher dose you're on with benzodiazepines, the more likely that is to happen. And we'll go into some detail and data on that. So that's also not, go back. In terms of, that's not only for benzodiazepine use alone, at least as reported, but also in combinations, particularly with opiate use disorder and opiate use. There's also an increased risk for suicidality and self-injurious behavior. And that reference, Dodd 2017, is in the reference material. I would recommend reading that a couple times because it can change your practice. Next slide. In terms of characteristics for benzodiazepine misuse, there's a lot of red flags, but things that are mostly described in the literature well are co-prescription for other controlled substances, particularly stimulants and opiates, and that reference is cited as well. And the highest prevalence, which surprised me a little bit, is in the 50 to 64 range. I really thought that younger populations for the folks I've seen, but if you look at the rates, he does a fairly good review. I recommend you looking at that reference as well. The sources, though, for that, and you'll see this on your board certification MOC tests, it's not only your healthcare provider, one or more healthcare providers, but friends, family. Oftentimes, I've had some patients recently that said, well, if you don't prescribe it, I'll just call my friend in another state and have them send me some. And you'll probably have that experience if you haven't already. Also, those folks that are in multiple healthcare systems, and we'll come back to that concept that really, if you're going to try to treat these folks, it's good to have them agree to be treating you with you only and not multiple systems of care, if possible. Next slide. There's been a mounting level of evidence over the past 15, 20 years, such that the FDA reviewed that material and came up with a new warning, in box warning. And this is a quote from that document that's also in your references. I'd recommend that you read that in detail. It says that benzodiazepines address the serious risk of abuse and addiction and can lead to physical dependence and withdrawal reactions among this class of medications. It also highlights the co-administration with opiates, and particularly can be challenging, especially initial dosing. And that's largely because of respiratory depression and some other effects that we'll talk about a little bit more. But I would warn folks that that's the risks, but there are there needs to be a balancing of the benefits as well, and done that on a case-by-case basis, because I don't think we should underemphasize that these medications do present rapid symptom relief, particularly for anxiety. It's more the longer term they're on it that is the challenge. So really short-term use with agreed upon in the right populations and the right patients can be very helpful and effective. I think the best phrase I've seen as I was calling this literature is to use conscientious prescribing habits. That's in the APA textbook that talks about and reviews a good portion of this. I would recommend that chapter in the APA textbook as well. It's a good overview and a good quick read if you don't have time to go through all the references. Next slide. So what are the major points from this FDA guidelines that I just mentioned? They recommend the following of the risk of using it. And that means in the treatment contract, when you're first doing the initial assessment, and that you do assess for misuse, abuse, and addiction. And that means not only initially when you see them, but over the first few weeks. And also that you use caution when co-prescribing, especially with opiates. You use the lowest effective dose possible, and we'll go over that more in detail. And that if you inherit folks in your practice that are on high doses, dangerously high doses, that you want to taper slowly. And that the take-home message that we'll talk about more in detail is that it's not just the tapering. You need to use effective therapies, particularly cognitive behavioral therapy, and some people argue maybe even contingency or some combination thereof, but effective psychosocial therapies that actually change the behavior of how they're using these drugs. And that you need to follow up frequently. If you're taking on this patient, you're going to have to realize that you need to see them every few weeks, whether it's from telemedicine, in person, some combination thereof. And that if you don't have the time in your practice to do that, you really need to consider, are you the best place for this person to be treated and the best prescriber for that? Next slide. So I can't see everybody, but you can sort of at least mentally raise your hand in terms of where you fit in this spectrum. Gebhardt et al. In 2007 talked about where are you in terms of, and this was before the rates really started increasing in terms of use, abuse, and actual related morbidity and mortality from benzodiazepines. But most folks that are conservative use benzodiazepines only for those that are treating alcohol withdrawal and possibly acute mania. There's some evidence for that. There's also some evidence in the opposite direction, whether you should use this for acute mania, but there is evidence for that. That's why I put in the possibly. There's also those that are in the moderate risk strategy approach, where you use short-term. Short-term means 4 to 6 weeks, typically, not longer than that, for insomnia, for panic, and those that don't have current active substance use disorders. And then there's those that are more liberal, that have been prescribing long-term benzodiazepine, and they've used it for folks with psychosis, chronic psychotic conditions, anxiety disorders, and even substance use disorders. I think the data overall shows that liberal use is probably why we've got this population of folks in all of our healthcare systems in this region that are having problems related to the chronic dosing. So I think I would recommend, at least from my review of the literature and clinical experience, that somewhere in the conservative to the moderate range is probably where most people want to stay. Next slide. Next slide, Debbie. So these are just some basic questions as we move forward in terms of our conversation. Asking yourself, how do I manage the treatment of patients with long-term benzodiazepine use, or who may be developing a benzodiazepine use disorder and co-occurring mental health disorders? And when and how do I determine if it's safe to prescribe these medications in patients who have substance use disorders and co-occurring disorders? Next slide. So there's really a lot of different types of patients who are using high-dose benzos. There's those that have been long-term benzo users that I was describing, and they originally started with reasonably moderate therapeutic doses. And as tolerance and other conditions happened and stressors, they increased what medication doses they were using. And that sort of led to a slippery slope that they really felt that nothing else would help. The problem is that when they do that, not only are they using more sedative hypnotics, they're likely to use alcohol in particular, opiates in particular, but probably some other medications to help counter the effects, stimulants in particular, because of the sedation with these dosing. And it makes it very difficult to cut back. It also, physicians get scared because of the amounts that they're taking, and that will lead to doctor shopping and a whole range of behaviors that are very challenging to address. There's another subgroup of folks who specifically use it recreationally, specifically to get high. We'll talk about the pharmacokinetics and pharmacodynamics in a few minutes, but the higher dose that you use, the more of a euphoric effect you get. And that's both for acute dosing as well as long-term dosing as well. So those are important factors to be thinking when you're saying, what dose am I inheriting in a patient with it, or what dose am I going to prescribe with that. And then if you have someone who's using benzodiazepines with alcohol, opiates, or other drugs, the euphoric effects can be even higher in addition to the negative effects like cognition and other side effects, respiratory effects. So you have to really think of the dose patterns of what people are using, not just their long-term effects, but really trying to map out in your evaluations what kind of dosing they're actually taking. There's a fourth group that are basically loosely described as non-medical use, and they may or may not meet criteria, at least in your initial assessment of a substance use disorder. But when you try to set some form of limits or tapering, they really do start to fight you, and that you realize, this is a bigger problem than I thought, and that you're also getting collateral information, that they're getting the benzos, as I mentioned earlier, from family and friends, and that this is a problem, and it's not necessarily something that you've been prescribing. There's a fourth group that come in or are treated either in primary care, more often actually with primary care than even within psychiatry, with sleep problems, and then they often may have a co-occurring alcohol dependence or use disorder, or they may develop the alcohol use disorder over time. This is particularly true with geriatric populations, and I think Anderson will probably touch on some aspects of that moving forward in the next talk, but also to realize that the sleep problems don't stop with the benzodiazepine use. They'll try Z drugs, they'll try a whole range of different things because the sleep gets worse and worse. And it's this vicious cycle that they don't necessarily have a co-occurring psychiatric disorder, but the sleep problem is so much that they keep pursuing higher doses, and that actually feed forwards in a negative way the problems and the side effects that happen with that. There's other subgroups, but these are the ones that I've seen the most of, both in my clinical practice and supervising fellows and residents. And I'll give some case examples and what to do about that a little bit more. And in the discussion at the end, I'd be encouraged and encourage other folks to bring in any cases that they have as well related to this or something separate. Next slide. So just briefly, take-home messages over the next few slides that we'll see. There's really been an increased use of benzodiazepine use over the past 20 years. And as I mentioned earlier, the increased death rates are and overdose death rates. It's hard to define overdose in some of these situations because it's chronic dosing, and these folks that come in, especially with things like severe COPD and other medical problems. I've actually seen some patients at VA, I won't mention specifics, but when they were given doses of their benzodiazepine at increasing doses in an inpatient setting, their O2 sats went from 90s to 70s, just with increasing dosing of the benzodiazepine on a controlled unit. So the death rate, an overdose is an arbitrary term. Sometimes it's intentional, a lot of times it's not, and it's just that the therapeutic index and the drug interactions are such that it's not a linear thing. It can be sort of a pretty big drop off that you increase that, you decrease respiratory drive, and you can kill a patient fairly quickly just increasing the dose, 20 to 40%, which is a scary thought to think about in those sort of settings, particularly when they're using opiates and benzodiazepines in medically compromised patients. Also, most patients who are using benzodiazepines that will come in that are difficult to challenge have been taking it for years. And they'll say, I've been taking it for years, doc. Why are you doing this now? And you have to first earn their trust. We'll talk about how you might try to do that, but also give them some solutions for what it is that they're trying to treat. Because a lot of these folks are trying to medicate a problem that isn't been adequately addressed in terms of whether it's sleep, anxiety, comorbid psychiatric problems. We'll come back to that in the case material. Next slide. So this is just a slide to summarize. I don't know if it's a fairly detailed slide, but it summarizes a lot of the data I've just mentioned. Since 1999 through 2020, the blue bars are all benzodiazepine deaths. These are overdose deaths, but again, that's determined by what was documented, whether these were accidental overdoses or intentional. I looked through the data and it wasn't very clear, but you can see the rates have steadily been increasing over the early 2000s to 2010s. In terms of 2020, the data through COVID, I tried to find some stuff through 2020, 21, but with everything, I think it's clear, you look at alcohol rates, it's probably like 30% plus increase use for that. Benzodiazepine use, not a lot of data, but it's probably somewhere in that neighborhood as well. So that line for the second line, benzodiazepine combined with synthetic opioids other than methadone, you can see that that took an inflection point in 2019, 2020 from all the data that I saw pulling this talk together. And otherwise, it's probably, if anything, steeper curve going up. So it's probably getting pretty high with the opioid death rates as well. And then the last one in the gray bar hasn't made a lot of points in terms of opiate benzodiazepine without an opiate use disorder or opiate use. That's then fairly flat, but that's probably inflected upward as well. So the basic take-home message from this slide is that the rates of opiate and other interactions are increasing, as well as benzodiazepine use, and therefore the overdose death rates are likely very steep curve going upward at this point in time. Next slide. So I won't go into this completely, but just this is the DSM-5, and we compared the DSM-5 versus the TR version. And it really hasn't changed in the current version of the DSM for the DSM-5, but it's a problematic pattern of use, as with all drugs of use disorders, for sedative hypnotics and anxiolytics that have caused impairment or distress. A lot of these folks will deny that they're having impairment or distress unless you take a very careful history, and then you become more clear. And it needs to be at least 2 of the following symptoms over a 12-month period. Now, I will mention a couple things. Tolerance and withdrawal, if it's in a controlled setting and it's under medical supervision, is not sufficient to create a diagnosis for substance use disorder for the sedative hypnotic space. And so you need to factor that in. If they're using it and they're having loss of control and impairment, some of these other areas, then yes, you do. But a lot of folks that are being prescribed in primary care will have a certain amount of tolerance and withdrawal, but are not misusing it. It's just that the prescriber has been prescribing too high a dose for various reasons. We won't go over the specifiers unless there's clinical questions later on, but that's there for your information. Next slide. So just the pharmacology, again, sort of the take-home message from the next few slides, that benzodiazepines, as probably everybody knows, bind to the GABA A receptor, and they cause allosteric changes in that receptor that increase the frequency of channel opening and hyperpolarization. That's opposed to barbiturates, which increase the duration of that. And to understand a little bit of that, it's good to look at the actual structure that causes these allosteric changes. Next slide. So what you can see, it's a little hard to see, but I tried to find a good picture of what the GABA A receptor looks like. So you can see that there's the alpha and the beta and the gamma. The benzodiazepine agonist binds generally sort of between the gamma and the alpha, or the alpha 1 as it's described there. And when it does that, because it's more external to the lipid bilayer, it does increase the frequency from where it's actually binding. That's compared to some other medications that look lower down in the chain. And the lower down that it goes, generally that's related to the actual duration of, because it keeps it open longer. So that's just a general way of approaching and thinking about how the GABA A receptor interfaces with the GABA alpha and the inhibitory effects of a given medication. If there's any questions about that, the Boren article is actually very good, 2018. I give you that reference. I believe that's also in the references. And it goes through each of these different medications, like the barbiturates that I was mentioning. You can see it's on the red under the beta there, and it explains how that relates to the pharmacology, but also gives you a better insight understanding of how these medications work in a pharmacokinetic and a pharmacodynamic way. So I recommend folks look at that. Benzodiazepine pharmacology. I'll just go over this quickly because it's better to talk about this really within case material. But the benzodiazepine sedation and euphoria that I mentioned earlier, it's related largely to the rate and plasma level rise of how quickly that happens. The pharmacokinetics, there's some discussions, and this is just a general guideline of how they are categorized. Some people would argue somewhat differently, but from the sources I was looking at, generally short acting is thought of less than 30 minutes of when you're actually having significant pharmacological effects. Intermediate is up to an hour, and longer acting is generally more than an hour. And those pharmacokinetics are related to not only the half-life of the medication, but the rate of the absorption of the specific benzodiazepine, as well as how well it is absorbed through lipid bilayers and the lipophilicity of it. Next slide, please. Okay, so here's where we start getting into why does it happen like this and why are these medications so dangerous? In terms of the physical dependence, we mentioned that over time that there's reduced GABA A receptor response the longer they're on it. But that's also because it also increases the expression of excitatory glutamatergic receptor effects after withdrawal, as with alcohol, that there's sort of a teeter-totter that happens, that there's always GABAergic and glutamatergic tone, and the longer folks are on it, the more GABAergic tone there really is. And if you take that away, then you kind of add more glutamatergic tone, which actually leads to a lot of the autonomic symptoms that you see from that. In terms of the addiction liability, that is how likely someone is to develop an addiction to it. A lot of it's depending on the speed of onset of the medication, the benzodiazepine particularly, of how rapidly onsetting it is. And the higher the rapid onset, the faster it is, the more likely that is to lead to addiction liability. In terms of the actual dose response effects or the psychoactive effects, the prescribing dose, for the lower doses generally do treat anxiety and sedation in combination with SSRIs and other medications that we can talk about. The higher dose it is, whether acutely or chronically, will lead to euphoric effects. And if you're asking yourself why patients become addicted to this, that's the driver. The higher dose it is, whether you're giving an acute dose or long-term chronic, if they're using it, just the dose itself with that, you'll get more euphoria. If you combine benzodiazepines with opiates, you're getting the euphoric effects potentially of the opiate as well as the benzodiazepine. And the higher you drive it, oftentimes the more patients will report they get more euphoric effects, and that's why they take it. So when they're starting to take it recreationally and then take a little bit more, go, that's pretty good, maybe I'll take more. That's why. And then the longer you take that, you get to a period though that you start losing those euphoric effects, which are thought of as good by the user, and they get into more intoxication states. And that's more like double the therapeutic range and up. I mean, these are rough estimates based on, there's some controversy of exactly what the dose is. And I've got some tables a little bit later to describe how do you try to parse that out. The higher the dose, the intoxication can lead to things like ataxia, falls, amnesia, stupor. And if you really push the dose, it can lead to impaired consciousness, nystagmus, delirium, and death. I didn't put death there, but death would be the natural consequence of pushing the dose too far. Next slide. So this is just a summary of what we talked about so far. This is from a VA academic detailing that I thought was pretty graphic. Like I said before, I wouldn't minimize that rapid symptom relief is helpful in a lot of settings, both for acute stabilization, withdrawal management, as we talked about. But as you can see, the risks are much higher than just the benefits. Increased overdose risk, limited evidence that long-term use helps anything, and it does lead to not only tolerance of withdrawal, but likely increased suicidality as well. Next slide. Okay, so that's just a brief summary of kind of a pictorial, but the other thing to really think about, and Anderson can talk about this more, is that there are evidences that the higher the dose and the shorter acting do particularly increase folks who are older to falls and significant outcomes from that in terms of adverse events. However, as pulling this, I did also find that SSRIs, there's a strong association overall that falls in the elderly also, so that if you're increasing and using SSRI as opposed to benzo, it's not like it's benign. So that you do have to factor that in. And the Gabera article, I gave the reference there that I would recommend folks looking that up as well. It doesn't seem to be causal. I looked at that to ask, do they think that it is a causal thing versus association? My best read of literature I reviewed is that it's probably related to combination effects and not just SSRI, but it could be. There just haven't been enough well-controlled studies to tease that out. But clinically, I think it's important to be aware and educate your patients that the risk isn't zero, but it's probably less likely than it is with benzos. So it's safer than, it's not safe, but it's safer than using benzos in geriatric patients. Next slide. Okay, so in terms of the effects cognitively, there's a whole range of them. And I won't touch on that a lot, but just to hit some high points. Amnesia, particularly anterograde or future-oriented, that they will have that they just won't remember anything you've said. if you're talking to a patient and they're using high doses of this. There's also unrelated sedation that may be affecting the cognition. And it seems to be worse that both of those effects with high potency benzodiazepines. And here's the other key point here. Nighttime use is not just benzos generally. They're oftentimes using binging with Z drugs as well. And there does seem to be some effects that if they're using combination Z drugs with the benzodiazepines, that the cognitive effects are more extreme. Next slide. So this is just a summary of some of the side effects. And this is from a meta-analysis that was done that showed moderate to large effect sizes. If you look on the y-axis, it's cognitive impairment of the weighted mean effects, so that you can see the average and the far overall is about a little bit less than 1. It's about 0.85, 0.9 effect size, that they're having some cognitive effects. And this includes things like sensory processing, motor speed, nonverbal memory, visual, spatial, speed of processing. When you're thinking about this, if your patient is driving and they're using large amounts, it's basically like they're driving around drunk all the time, and their reaction speed and all that, their concentration is going to be impaired. So you have to think about practically how's that affecting their day-to-day work with that. The other thing that to think about, verbal memory is not great. It's about 0.6, so it can be impacted. So if they're using large amounts and you're talking to them, they may not remember what you said. So printing out your material, the multiple ways of reinforcing it, giving them their scripts, writing out what you say, all those sorts of things are in play when you're meeting with folks because of the cognitive effects. And their working memory. So it's not just verbal memory, it's their working memory and their verbal reasoning. All these are impacted. So you really need to think in terms of, as I'm prescribing this, asking yourself, what kind of cognitive effects is this likely to have for this particular patient, is the take-home message. Next slide. So those are just some of the effects of that. In terms of the risky behaviors that you'll see in your patients that can lead to this presentation, you can have patients that are using more than prescribed, saying, "Doc, I called, I just ran out of the meds. Can you prescribe and bridge me till the next effect?" Or they're using more than prescribed, which leads to that, calling for early refills, the doctor shopping we mentioned. And then they're also using benzodiazepines and other drugs, and we'll touch on a few of these. If we had more time, we could go over the whole panel of that. But the take-home message ones that we'll go over in the next few slides are things like Z drugs, things called designer benzodiazepines and gabapentin. But they're also, as I mentioned, using opiates more often. They're using stimulants more often. It's a polydrug pattern. So even though I'm focusing on benzodiazepine, when you think of benzodiazepine use and abuse and disorder, think of polydrug use and which ones and what are the interaction effects. And they're often using this combination when they're feeling upset or feeling it's sort of a self-medicating type of picture. And it truly is that. So you have to think of which are the primary psychiatric conditions that underlying that are driving the polydrug use. There are some that just use it just to get high, but that's actually fairly rare. It's more likely that they're using it for both some co-occurring psychiatric disorders and then some substance-induced mood and anxiety disorders that are related to the drug use. So that vicious cycle that I've been talking about. Next slide. Okay, which of ones are often co-occurring? I just did a cull of the literature again recently, and there's a whole literature developing of new designer drugs in general, called the novel psychoactive substance. And it's been touted mostly by World Health Organization, and there's other folks coming in. CDC's beginning to talk about this, some other folks, but it seems to be mostly been observed more in the European literature for reasons. And they'll talk about things like legal benzodiazepines, designer benzodiazepine, research chemicals. If you just Google research chemicals, you'll come up with some really interesting hits there. It's sold in all different forms, everything from tablets to powders to pellets, blotters, liquids, probably some other things that are in there as well. And there's really very limited information at this point on the pharmacology, the toxicity, because they have to discover it, then analyze it, but they're always coming up with new congeners of this. The Orlinsky, this article that I mentioned for the 2020 covers that, and there's table upon table of these. And we don't know what the pharmacokinetics are, any of these, because they're just coming out more quickly than people can study them. And it's an international problem. This is all of Europe, There's some evidence probably in the US this is happening. So when people are using benzodiazepines and you're prescribing them where they're coming into your office, you not only want to think, what drugs do I know about, but what drugs are they possibly using, or have they ever used any designer drugs in general, and screen for that. Next slide. Z drugs, we talked about. These were touted because it was realized that if you go back in the literature, people were using things like barbiturates and other medications years ago, and benzodiazepines were thought to be safer. And it's found out, well, yes and no, as we were talking about. And so Z drugs were sort of the next generation of trying to do that. I won't mention all the examples, but the point is that they were developed to be safer alternatives for sedative hypnotic effects other than benzodiazepines. They're structurally different from that, from the benzodiazepines, but they do bind selectively to the GABA-A alpha-1 subunit that I mentioned previously. And they're thought to be more selective, and possibly they are. There is some evidence from human lab and animal studies that that's true, but it doesn't mean that they're not safe. They may be slightly safer than benzodiazepines, but they're still showing a lot of evidence of tolerance, physical dependence, and abuse in the post-marketing brand article I mentioned here, but there's more recent ones. It's just an emerging literature that the Z drugs probably are not all that much safer, honestly. And you'll see folks that they're using Z drugs typically are also using benzos, if you really drill down to that. And the other thing that you'll notice that after a while, the efficacy seems to decrease a little bit with the Z drugs. And there also seem to be more evidence of parasomnias and sleep driving and amnestic effects and doing things and not remembering doing it. So when you're driving in the Boston area, if I'm thinking about the population of folks that have been using Z drugs and benzos, if they're sleep driving and not remembering what they're doing the next morning, that's a risk. That's probably happening. Next slide. Okay, gabapentin misuse. Again, an international problem. This data is pulled from these different countries. The overall rate from this is actually a well-done study from 2016. The overall population misuse is about 1%. That's off the streets. The gabapentin prescriptions who are misusing it is up to 65%. So about 50 to 2/3 of your patients, 50% to 2/3 are probably misusing it. And those with opiate use disorder, it's probably somewhere around 20%. So that's across multiple countries. So just something to consider. The types of misuse that they describe are both recreational, at least that's how they're starting it, or they're self-medication for some of these psychiatric conditions that I was alluding to. And it can be in combination with not only primary psychiatric disorders, but also in combination with other drugs. And the ones that are the most dangerous really are the opiates, co-occurring benzodiazepine, and alcohol use disorders. Not mentioned here, but talked about is also folks who are saying that they're having cognitive problems and people prescribe stimulants, and that's often because of the effects of the benzodiazepines and the alcohol itself. And so you're not really treating the condition, you're just adding another dimension to the problems of what you need to deal with there. Next slide. So I won't go into the details of all of the clinical assessment, but just some useful tools to look at specifically in terms of dealing with this population of folks who are using high-dose benzodiazepines and co-occurring psychiatric conditions. You do want to use urine drug screens regularly and effectively interpret them. And you want to think in terms of not only the benzodiazepine dose equivalency, but the dosing recommendations as it relates to the risk. And it gives you some sense of the risk. So there are two separate things that I'll tease apart, and then look at the benzodiazepine withdrawal syndrome, both its short and long-term effects and how it is similar and different from alcohol withdrawal. Next slide. So I won't spend a lot of time on this. If we had more time, I would, but the urine drug screen is key. And I would do some homework on that and look at the references that they do talk about that, particularly the chapter in the APA textbook. But the immunoassays often miss the synthetic benzodiazepines. There's a false negative, particularly with alprazolam, which is often the most misused, lorazepam, clonazepam. There's others as well. But those are the ones that, and when I'm saying immunoassay, you do a screen, and then you do the GC mass spec. So I would order GC mass spec if you have any suspicion. That's a secondary follow-up. And you have to talk with your lab and make sure that with this new emerging designer drug, talk with them and ask which ones are they seeing, or ask them to talk with their poison control because the labs and the poison control often talk regularly together, and just find out what you want to add for that. But get to know your lab staff and get to know where your poison control is and talk to them, depending where you're practicing. Next slide. So this is just a busy slide. I won't go into all of it, but just to give you some idea, this is based on a review of 4 or 5 major reviews of what the approximate dose equivalency is for benzodiazepines, the elimination half-life, as well as active metabolites that are in parentheses, and the interactions with the cytochrome system that were alluded to in David's talk as well. The metabolism is actually particularly relevant when you're talking about specific cases and combinations of medications of what can happen in the presentations. But the one that's most misused is alprazolam. By all reports, elimination half-life is 6 to 12 hours. It's a CP3A4 primary is the metabolism. Some of the others you can look at and see what their metabolism is. But this is based on multiple reports, and this is a pretty good table to work from in terms of that. This is also in the APA textbook. Next slide. So that's setting the stage for dose equivalency. That's not the same as what is the risk profile. And even though this doesn't map on necessarily with the dose equivalency, this is based on looking at PDMP, DuPont, and others talked about this in 2005. I think it's still relevant today, that the lower risk are generally about 1/2 of maximum dose. So you can argue what the lower risk, moderate risk, and higher risk is based on the dose equivalency, but this is just an approximation of looking at the thing, so that if they're using, for example, alprazolam more than 2 milligrams, you know you're at more than low risk, generally in most cases. Same with clonazepam. But just something as a general guideline when you're looking at, I would look at the dose equivalency as well as the risk profile just based on the dosing as independent factors in your assessment and treatment plan. Next slide. Okay, what does the withdrawal syndrome look like? Well, it does look a lot like alcohol withdrawal with some twists, that even with low dose and cutting back over more than 6 weeks, 4 to 6 weeks, you will get a withdrawal syndrome in most cases. And it can have, I won't go into all this, but there are physical symptoms and psychological. Some of them you wouldn't necessarily think of for the psychological. Not only you look like a bipolar picture in some cases, but you'll get more nightmares, especially with folks with PTSD. And the perceptual changes, oftentimes, people will describe things like photophobia, hyperacusis, dysesthesias, all those sorts of things, and you think it's a physical manifestation, and really it is a physical manifestation of the withdrawal syndrome itself. And the thing that's different from this from alcohol is based on the half-life of the benzodiazepine, that it can be much more protracted. So not only do you get anxiety and sleep disorders, but you can get increased risk of seizures, generally grand mal seizures. And I've seen this in clinical practice in the VAs I've worked at. I've seen a number of patients discharge, and they didn't give a tapering dose, and they didn't actually capture that they were using large amounts of benzo. So they discharge them post for alcohol withdrawal management, and then they have a seizure. I've seen some actually at 96 hours being discharged saying that they're okay, and they have a seizure walking out the door. And that was the story why. So you really do need to think of terms of if they're using a combination in the benzodiazepine, generally the seizure risk is further out than it would be with alcohol. And that's one of the major differences to think about. Next slide. In terms of factors contributing to this withdrawal severity, we kind of touched on this, but just to summarize. So it's the duration of use, generally more than a month, the dose that they're using, how quickly you're tapering it, and the half-life. In the previous tables, if you look at those 4 parameters with the specific cases, you can kind of piece together what likelihood is of the pharmacokinetic profile and the withdrawal severity. You can fairly well predict it. I tried to find out if anyone's actually, it seems like that would be a good research study to look at predicting that, but the rates are slow enough and they're difficult enough population that no one's actually tackled that. But I think that would be an interesting study to predict withdrawal seizures based on these parameters. Next slide. So what do we do? It's complicated. There's lots of moving pieces with this. Unfortunately, there's no FDA-approved treatments for this, but there are some emerging guidelines. They're not consensus, though. There's enough literature to reports that. But there are some limited clinical studies, small numbers, unfortunately. There really are no large prospective double-blind randomized trials. And I think it's in part because these are very difficult patients to engage and keep in treatment. And there clearly are no published meta-analyses looking at benzodiazepines, comparing it with SSRIs for treating anxiety and direct heads-up comparisons. Next slide. But so what to do? So I tried to call the literature together in terms of what is available, and the basic will go into more detail. But if you look at a benzodiazepine taper, it used to be much longer, but now folks are thinking of weeks to months, plus psychosocial treatments. That's generally the guideline in most cases. And you want to try things like particularly cognitive behavioral therapy, relaxation therapy. You may want to consider mood stabilizers, particularly carbamazepine. We'll go into that in more detail, but there is some data from Malcolm and others that show that carbamazepine outperforms benzodiazepine for sleep and anxiety in some studies. Next slide. So what does the most recent benzodiazepine show? For the pharmacological interventions for discontinuation, again, the data is fairly low because of the difficulty of engaging these patients. And there's very uncertain data in terms of whether valproate and tricyclics increase the chance of decreasing that. And it's also unclear that other medications to treat benzodiazepine withdrawal, including carbamazepine, pregabalin, and paroxetine, due to bias and chance occurrences. But the data overall is stronger for carbamazepine. So of the choices that are not great, carbamazepine is probably the best. But the tolerability and safety profiles are not reported across all studies. So that's a major deficit in the literature. So what to do? Well, there's a number of different methods that have been used. Probably a lot of folks in the audience have heard of the Ashton method. It's frequently used. There's very little supportive data. It's mostly clinical experience and case reports or small pilot open label studies. And the basic idea, she touted switching to diazepine, but any of the long actings probably would work and taper over a month to a year. The MGH algorithm that I've talked with David about, is looking at alprazolam to Klonopin switch. So again, short acting to a long acting form. That's been described by Herman et al. In 1987 in the handbook from the MGH that describes it. It's based on open study, and it's switching to Klonopin about half the dose of the alprazolam dose. And you can read through the slides and do it in about 7 days and then continue slow taper. The real difficulty is when you get down to the 0.25 to 0.5, they're going to fight you to get off that. And these are, again, are for patients who primarily were panic disorder and probably not polysubstance using patients who are going to really fight you hard. So how well that applies to a dual diagnosis population, that's an empirical question. So next slide. This is probably the best literature I've found that goes over this. This is a New England Journal article from Soika, 2017. And they recommend a taper over month and a half, maybe longer, and to use the carbamazepine, about 200 milligrams twice daily as an adjunct. The therapies that they're describing, they touch on it in psychotherapies. I'll go into that in more detail. And the reason they have a reasonably quick is they want to have avoiding the fact of the morbid focus of the withdrawal and kind of get through it. You do need to think about whether you're going to do this in an inpatient or an outpatient setting. And you have to consider if they're using more than one benzodiazepine to move to one that's longer acting and do the taper. You can describe more detail looking at those articles and the ones that are cited in terms of the dosing recommendations. Each of those vary. But I would recommend reading that article if you're going to read one article from this talk. Next slide. So what to do about rebound? You can withdraw folks over a 4 to 6 week, 3-month period, something in that neighborhood, but you're going to get some rebound in terms of insomnia, anxiety. So I would recommend take a message of using probably carbamazepine if it's tolerated and it's not going to liver induce other enzymes that are going to affect their overall drug medication profile. Possibly Depakote, possibly gabapentin with the caveats that I've already mentioned. And you may want to continue the anticonvulsant and check levels. There's also some suggestive evidence that SSRIs can be helpful, as well as using anxiety medications like pregabalin, gabapentin, and beta blockers. For insomnia, there's really no good remedy. All these have been suggested in this, including melatonin, the antidepressants, possibly trazodone, some of these others mentioned here. They are somewhat helpful, but there's no real clinical data to guide us on that in terms of clinical trials. Next slide. this is the key and one of the real take homes from this entire talk, that you're going to try these different medication algorithms, but if you're not using some form of effective psychosocial treatment, you're not likely to be successful. And Vanderup, this is a very well done meta-analysis of the data that's available for the psychosocial treatments. And they take away is that cognitive behavioral therapy in the short term, that's for 3 months, does help decrease the use during that period. They did not have data for 6 months and longer, which is a gap in the literature. And they looked at motivational interviewing as well. That in and of itself didn't be sufficient, but motivational interviewing with CBT probably is effective. So the take-home message from this is, if you're taking this patient on, you do want to have them working with a therapist concurrently doing some CBT, and you are likely to have some success if you do that combination. But just to do it in a kind of a psychopharm clinic with no cognitive behavioral therapy, you're likely not to be successful. There is some evidence that tailored letters and other things talking about that does get their attention and raise their motivation a little bit. That's also talked about in the article. The standardized interview versus treatment as usual, a little bit less data and relaxation treatments, just understudied enough. We don't really know. There needs to be more trials looking at that, these different approaches to see which combination of psychosocial treatments is the best for the given population you're treating. Next slide. So back to the cases. These are the common scenarios. There's not a ton of time, but just I'd like to hear other folks' cases and questions, but think to consider what ages are you treating in addition to folks in the treating. Are you treating someone in their early 20s to 30s, 40 to 65 or older? As we mentioned, the rates from the 40 to 65 are increasing. The adverse effects older than that are amountingly increasing, and we'll talk about that probably a little bit in the next talk. So basically using a collaborative relationship with a therapist, cognitive behavioral therapy, also consider family and psychosocial treatments, possibly MI. These treatments with that, you're likely to have some success, definitely more than you would without trying that. Next slide. So just to summarize very briefly, as I had mentioned, there really is limited data. The best overall description, I think, of what I could call together, Sequoia et al. Is a good read, using the adjunctive treatments as needed and combining it with psychosocial treatment, you are likely to have some success. If you're taking on these kinds of patients, I would recommend frequent reevaluation and consultation and collaboration with your psychotherapy folks. Next slide. Future directions. I do think that I was just struck, usually when I present a talk, I look at the meta-analyses and then kind of pull some of the specifics. And I realized that the quality of the data overall was poor to very poor. And I think it's just because this population is so difficult to engage, it's difficult to give specific treatment recommendations when the data itself and the non-adherence is so high that it's hard to make significant interpretations. But the data does suggest that randomized effects that using relapse prevention will help. But the other take-home message for folks that are interested, there is room for meta-analysis and there are emerging studies in this area. So I think the more we can do literature reviews for this, the better we'll be able to treat these folks. Next slide. Just in terms of open cases for folks' questions, future directions, any collaborations, I'm opening it up for any questions folks have. These are just references. The ones with the arrows are the ones that I'd recommend you reading if you wanted to look at those. We have a lot in the chat. I don't know where to start. David, did you want to?
Wow, yes, you've had a lot of questions in the chat on that wonderful talk, and it's you've stimulated many questions. I don't know how to pick from among them. Maybe you could.
We could also, toward the end of the day, parse some of those out and maybe call those over
do
lunch.
what I did, which is while you were talking, I answered some of the other people's questions in the chat. So when you get time, you could do that, and then later people could check the chat and see the answers to your questions.
Yeah,
I thought the very last one, or second to last one by Michael Hanna, was that clonazepam withdrawal can be as brutal as alprazolam withdrawal. Ashton recommends diazepam, saying it's self-tapering, but what's your experience with those two, if any, to compare them?
Yeah, I've done both. I would say the only times I've had effective withdrawal of actually getting people off, whether it's diazepam or clonazepam, is if I was working with someone that's doing regular CBT, honestly. So I don't honestly think there's no controlled data for it that I'm aware of that direct heads-up comparison. But I do think when you're talking about dual diagnosis population, if you don't have psychosocial treatment, no matter what long-acting form you take, I don't think you're going to be effective. I mean, it's the bottom line.
Let's see. I want to remind everyone that when alprazolam was new to the market, Mass General was treating people with up to 8 milligrams a day. So this problem has been long in the making. But then others have said, what about the more typical patients that are using 0.5 to 2 milligrams chronically at HS? And just many questions about alprazolam. Alprazolam's the #1 world's best-selling benzodiazepine. So people are using it all over the world, yet it has all these problems. Any further comment you want to make about it?
I think having frank discussions with the patients over time of what not only the risk is, but the alternatives. It takes a while to have folks trust you enough that they think you're going to cut them off at the knees and stop the medication. But if you kind of do it in more of a, we're in this together and we're here to help, and what your goals are, and identifying more what it is that they're wanting to treat. Because a lot of times people will say, I just need this medication. And then you say, okay, that's understood. What, is it anxiety? Is it PTSD symptoms? What is it you think sometimes I'll just focus and say, I just want the drug, but if you can develop enough of a relationship that you get past that and ask them, so what else is it that, you're using it for? And when you first started, and really get a good history and an understanding of because it probably did help the first few years. It's more that these folks have been on it for years to decades. And those are the ones that are most likely to have all these severe outcomes that I mentioned. So you really do need to get to know folks first. And I usually try to meet folks in the middle. I rarely, unless it's like, an inpatient setting and it's life-threatening, like this one patient I was mentioning, where their two sats literally went from 90% to 70%. You couldn't, you just had to act. But the ones that are not that extreme, I usually will say, yeah, we'll prescribe it, but I will gradually, and sometimes they'll leave. They'll say, you're messing with that. But if you're alleviating the symptoms and working with the therapist and they're less anxious, then it's just you're dealing with the drug itself and the effects of that and the rebound effects. But they trust you. And I've got one patient, I've got a panel that's fairly large at Brockton, and I'd say about 20% of my patients fit some version of this category. I have an N of 1 that's actually, and I just weaned him off the past month, off of benzos. But he was very motivated, well-educated, understood basically everything we talked about. So, I've got some of my work cut out for me moving forward. And I think all of us do probably in terms of that. So it's a long-term thing. I mean, realistically, even though they talk about that, unless you inherit them and they're very motivated, several months is probably ambitious. That's probably months to a year or two in a lot of cases, but just working with them, trying to make sure you're the sole prescriber, doing everything we talked about in this talk. And, you'll have some success, I think, in some patients, but minimizing risk and mitigating risk. And
here's a real quickie final question, but maybe you could answer some more of them when you look over the chat.
Yeah.
Very good contemporary question. How would you compare the liabilities of people using cannabis for their anxiety as opposed to a benzo?
It depends on the dose of the benzo and what else. I mean, the dose of the cannabis. A little bit of cannabis probably is not going to. It does have some cognitive effects. There's some data showing that high dose will have cognitive effects long term. It's probably less risky than the benzos. That's my gestalt. I mean, so given the society using it, but the combination of the two, that will have added sedative effects too. I talked to the patient about all that.
All right, well, that was fantastic. And the questions continue to pour in, so maybe you can do some of them, but I want to.
Yeah, I will answer as many as I can, but also we can talk about this more at the question and answer.
We will have time at the end of the